They shouldn't be eaten, it's not food. And here they are out of the ear. Like I said, not much, and that's a close-up of that bit. The bigger one, anybody who's a fan of fungal infections, peeling and mastoid cavities, you've got all three in this one. So yeah, triple whammy in here. Now this fella, I think he has been in one of my videos before. I want to say it was episode 100. You feel free to go and find that one. And he had something quite similar in that he had a fungal infection, but it wasn't as bad as this. But you could clearly see a few spores in it. But you can already see that it was kind of, I say eardrum in the distance, that's not his eardrum actually, he's had a graft on this. I'll go into that in a bit more detail a bit later on. But more the problem here is all the peeling that we've got to do of all this stuff to prepare it for the treatment. I started with a fine end tube there, and I quickly realised this stuff was a bit thicker and a bit more stuck than I thought it was. So I think in a second we're going to take that off and go with the full-size tube. Now they're not separate tubes, one fits on top of the other. You got a standard tube, and then you just the fine end is just a little attachment that you put on the end of it that makes it narrower. But yeah, it just wasn't cutting the mustard there, so to speak. So I've took that end off, and now we're using the full-size tube. It does get a bit glary in a minute here. I quickly realised it was glary as soon as I peeled up this, and it started reflecting back at me. So I did turn the light settings down. It does become a bit clearer after that, just bear with it. I want to say bear with it. It's a long video, I'm not gonna lie. It's a long 25 minutes. It took a long, it was so fiddly. It was so fiddly and difficult, because now to get stuff off this, when you're ordinarily doing these kind of peels, it would be slightly easier if you can use any oil or drops, but you shouldn't really do that. It should be a last resort anyway, when you've got a fungal infection, because it can make things worse. But, you know, if you're putting olive oil in there, you're essentially giving the fungal infection some food to nosh away on, which obviously can make things worse. And some of the drops are water-based drops, water and fungus, big fans of each other. So fungus tends to grow in anywhere warm, damp, dark, which is exactly what most ears are. Now this chap, he knows not to get water in it, because it is quite a persistent problem that he gets in his ear, but it's notoriously difficult to get rid of, these fungal infections, because you can clear away as much of this as is humanly possible. All it's doing is preparing it for the treatment. It's not getting rid of the underlying infection. That will still be there, but as soon as you peel it away, you're giving the treatment a better, which is fungal drops, which is giving the treatment a better chance to work. You can expose as much of the ear canal as you possibly can. But that's the whole purpose of this, is why I'm trying to very carefully and gently peel away as much of this as we can. So yeah, as well as this fungal infection that this gentleman's got, he's had a mastoidectomy, and some of you regulars will know exactly what that is. For those of you who don't, mastoid bone, a bit there behind your ear, and it's like a honeycomb structure, and what can happen is you can get infection in that bone, and if that doesn't respond very well to antibiotics, then what they have to do is drill that bone away, which essentially leaves you with a much bigger ear canal than you had to start with. So to the right, you won't see it yet, you'll see it a bit further along the video. There's not actually a huge amount in the cavity. Just see, you're just about to go and get the next bit. The most, I was really surprised with it. I've got to come on to the mastoidectomy in a second. But have a look when this section at the roof of the ear canal comes out. You'll see that underneath it there's just as much fur and fungus as there is on top of it. I was really surprised when this came out, just how much there was. This is the bit that you saw at the start of the video. Bit of a tricky spot to get to here, right at the roof of the ear canal. So to get the right angle with a suction tube is proving a little bit tricky. That's why I just came away a couple of times. But let's just go and grab that, hopefully get a decent grip. And it pulls a huge chunk that's stuck to the roof of the ear canal. But have a look when it comes out. All the, can you already see it there underneath? A load of these fungal spores, hyphae, that you can see on there. It's an absolute belt of that, isn't it? And it felt better as soon as that came out. But again, you can see what you've got left a bit deeper down is a lot more soggy. So it's a little bit of discharge and, you know, dead skin, all sorts of horrible, nasty stuff. And we do, you're not going to see a 100% spotless ear canal after this. Not far off. Because it's nigh impossible to get every little speck. Like I said, you're just trying to give it the best chance for the treatment to work. So yeah, going back to the mastoid. So it was a number of years ago. So we had to the right of where you're looking at the screen now. The ear canal, it's missing. It's not there. because it was drilled away because of the recurring infection. It just couldn't be treated, so they drilled it away. So now you see slightly on the right hand side there is like a U shape. Ordinarily the ear canal goes round like that, slightly oval shape, not elongated, but around about that section there, just to the right, you can't see it, you'll just see a ridge, or like a ledge if you will. And then there's another space, which is probably just as big as the ear canal, on that side as well. So we'll get to cleaning that in a bit. And that was the bit that was probably more tricky than this bit. I think we decided to come back to that in a bit. So I'm going to start peeling away this. So this wall here that you can see that's covered in this debris, that is the old canal wall. And you'll see as we start to peel a little bit of it down, that you'll see there's a ridge on it. But getting the clearing cavity is notoriously difficult. It's really tricky. So that's where this is coming from here. It's coming from around that corner that you can't see it yet. But you trust us, there's a big opening in there. And that's the bit that's really difficult to clear because it's a very difficult angle to get into. You've got to go straight and then a really sharp turn to the right to get in there. Now this is where the cavity is. So that's not where your traditional ear canal would be. And that's where this is coming from. Fairly substantial chunk there hidden around the bend. Very slimy and discharged. Can you just see the ridge now? There it is. Just about 3 o'clock. Like I said, that's where the old ear canal was, and it was just drilled away. So yeah, it does come to see me every somewhere between 3 to 6 months. You start to see the lovely pink skin down underneath that, can't you? But yeah, it does get a bit time consuming and a bit tedious, this stuff, because it was difficult. It was really difficult to peel away. I know you guys enjoy slightly longer videos that you can see it's a challenge. It certainly is a test of all your skills when you get something like this. And yeah, it's rewarding at the end. It's not what you're thinking halfway through when you're trying to get this stuff out. It's horrible sticky stuff as well, because whilst you've got this dead skin, some of it's quite hardened up like this bit is. You've got this slime that's clinging onto it, trying to pull it back into the ear. So you can probably see the remnants of what looks like an eardrum in the distance there. It's not, because part of his surgery was when they drilled away. They had to remove his eardrum, and they grafted a fake eardrum onto there, which they did a pretty good job, to be fair. And they also, he is okay through that as well. He tells me, now I don't have the notes of the operation and surgery, so I don't know the fine details of it. But he did tell me they did quite a lot of work there, so they managed to keep a fair amount of his hearing. I'm not going to entertain going on that grafted eardrum, just to scoop away or to suction away some tiny little bits of slime. I really don't think that's worth the risk. Because like I said, this is not a normal eardrum. We don't know how thick it is, how thin it is, how it's going to respond if it's lightly touched. Absolutely not worth going near that. And after we've cleared all this, the drops, it's actually already got them because it is a recurring problem, so we can get it in straight after this treatment. It's hopefully going to kill the tiny little remnants that are left behind. But it was incredibly tricky. I do get asked quite a lot about the certain types of infections. Did they come with an odour? Did they smell at all? I'll be honest, very rarely. But I suppose as a nurse, my nose is quite well trained to be, immune to these kind of things. Possibly more so than a lot of audiologists that you'll see. I probably come across a lot of things that are a bit more than you would see, so I've probably got a bit of a stronger stomach anyway. But no, it's really rare that you get much odour at all, to be honest. You can smell when you start sitting there in the tank, but that's why there's a lid on the tank. You don't open it up and go near it with your nose, trust me, I've only tried that once. There are some types of infections that have an unusual smell. There's one called Pseudomonas. I believe you can get it in the ear, it's not that common. It's more common in wounds, leg ulcers. Pseudomonas, you can get kind of a green tinge to it, and that has quite a distinctive fruity smell to it. And once you've smelled that, you'll not forget it. But yeah, I suppose my previous career does prepare me for things that are a bit more difficult to tolerate, do you know what I mean? I'll give you an example. I did write a few things there, because I know this is a long video, so I thought I'll give you a few little tales. I know you do like them. There's only so much I can say about what I'm doing at the moment. You can see what I'm doing. I'm peeling away at all this stuff here. So yeah, the kind of things that would prepare me, these are not. If you're eating dinner, or your tea, or your lunch, depends where you're from. Don't get me started on that debate on the north side of England. It's breakfast, dinner, tea. Not breakfast, lunch and dinner. Anyway, I digress, I'm distracting myself again. Yeah, if you're eating it, maybe put it down for a bit, just in case any of these little examples might make you want to bring that dinner, tea, breakfast or lunch back up. I know a lot of people are interested in what I used to do And like I said, I'm going to give you these examples to kind of help you out to understand why this stuff really doesn't bother me at all. Some of you might be looking and thinking, you know, if it doesn't bother me at all. So some of the worst, not worst, more interesting things that I came across that helps you to get a bit resistant to this type of stuff is, I'll give you a few examples here. Like I said, I've written these down. This was a really common one whenever I used to, especially in care homes, when I used to go in, I didn't used to find it uncomfortable standing over people. I'd rather be at their level, so a lot of the time I'd kneel down. You should always look before you kneel down, because more often than not you kneel down next to someone's bed. In a care home, there's not enough carpet in, and within a couple of seconds you can just feel your knees getting a bit moist and damp, and you think, oh no, I'm kneeling it again. Because quite commonly, patients will have a catheter bag hanging over the bed frame, and so they have a little tap on, and they get emptied. There's quite a bit of spillages involved very occasionally. So yeah, I'm knelt in that a lot. As soon as you feel that squelch when your knee goes down, your heart sinks a little bit. But you used to carry a spare uniform. Exploding enemas, I had quite a lot of that. Look at this bit here that's coming out. A lovely chunk. And that's a great bit of slime. And again, you can see evidence of the fungus on that as well, can't you? The little white areas. Got some more images of it towards the end as well. Explosive enemas. We don't know what an enema is. It's like a squeezy bottle. Imagine a baby's bottle, and it's got a little tip on it. These enemas, you put them where you all know where they go, and you squeeze this liquid in, and if you're not careful, if somebody's that constipated, you'll get a blowback. That's happened a few times. These were before the days where we wore masks as well. Spare the details. Probably the one that turned my stomach the most was I was doing CPR resuscitation on a gentleman, and again this was before the days that you got given pocket masks. This was in the community actually. Anyway, it wasn't in a hospital setting. It was just by the roadside. Happened to be a passenger. I wasn't a passenger, so I was driving on my way home from work. Ironically, having just done a CPR training refresher, and we didn't have pocket masks then. We were given some, probably as a result of this. But as I was doing CPR, I met this gentleman that vomited into my mouth. And you're thinking, did you carry on with that? Like, if someone's life's at stake, you do. You just carry on. So you just spat it out and carry on again. What else have we found? Maggots. We used to treat wounds with maggots. Get them in a little tea bag. I've said these in a few of the videos before, but there was one time where we found them where they weren't supposed to be there. Nobody had put them there. They'd just naturally grown there in someone's toes. Here's the cavity again that you can see. Now this does take a while because it's such a difficult angle to get this into, bending to the right there, that it does take a while. You probably will get frustrated. I got really frustrated doing it. But it's very difficult to get the angle of the endoscope in around that corner to peel it off. Did as well as we could, so we got the majority of it. But yeah, it does go on a bit, that bit. What else? Oh, the one thing that really did turn my stomach. Every nurse will tell you this. They all have one thing that they're a bit about. Some of them will be blood or other bodily fluids. With me, it was bones that were either sticking out or pointing the wrong way. Probably because it's happened to me quite a few times. But I could never work in orthopaedics, but we still did have to see patients after they left orthopaedics. And whenever I read the letter that we got before going to someone's house, my heart sank when I saw the words either halo or emitter off frames. Some of you nurses will know what these are. Halo is when you'll have like spikes, metal spikes going into the skull there with a metal ring around it. Keep things secure and stable in there. They're particularly grim. And laser off frames, you'll see them on people's legs. So you have a leg and you've got like spikes going literally into the bone all the way around, and then frames all the way around it. Keeps it stable whilst it heals itself. I believe there are some that you can kind of adjust that they slowly move together so you can get those bones to join together, but I was not a fan of those at all. So a lot of gunshot wounds, stab wounds, that was really common. So a lot of people with limbs that were not there or half missing, unfortunately, we used to have to dress the stumps until they healed. So a few craniotomies as well. Now, craniotomy, that's where the part of the skull is removed. And the reason for that is usually is when they call it the ICP, the intracranial pressure, usually following head trauma. Because I did a brief spell in intensive care, and with the brain swelling, sometimes it's swelling that much that it's got nowhere else to go. It's pushing against the skull, and that can end very badly unless you do that. I know they relieve that. You have to drill a hole around the back here. I've seen them all over the place. So it literally opens up the skull, so the brain can then expand, and then the pressure resolves. Those were pretty grim. I did see a fellow actually once who had an axe through his head. So he ended up with like this entire bit of his head from about there missing. And so his eye was down here. Yeah, that was one of the most severely injured fellas that I came across. I think I've told the story about the 20 stone scrotum that dropped on my head on another video, so I think it's in Nursing Tales, I want to say that was called. The long one, that. What else used to make my stomach go? Actually, one thing that was quite similar to the job I used to do was tracheostomy, suction. Now it's that, obviously you know what a tracheostomy is. It's a little tube that's inserted through there. I think numerous reasons why they can do, you know, if someone's had surgery on the mouth. And the tracheostomy tube, you can still create mucus and slime, so a lot of people, you know, they tend to cough quite a lot because they can't expel the mucus as well as they could. So what you used to have to do is put a suction tube into the tracheostomy and feed it in there and hoover all that slime out to make it easier for them to breathe. So not dissimilar, so I've done suction as part of another job. The one that turned me the most, and I really struggled with this one. Again, I think this was in intensive care. I saw someone who had a gunshot wound to the eye. It completely obliterated the eye. Obviously, permanently damaged the site, but what you couldn't do, they couldn't have this what was left of the eye left in there. So they had to remove it. And they asked all the nurses if they would assist the facial surgeon with it, and not one of them was keen to put their hands up, because obviously a lot of people have something about touching my eyes and what have you. It didn't bother me in the slightest. I've had 4 operations on my eyes, formed double vision, long story, clumsy child, thought it was 2 of everything, but anyway, it didn't bother me, so I assisted with that. But yeah, it was still pretty gruesome. I was basically just scooping everything out, what was left of it, with what looked like a crude spoon. That wasn't a very pleasant one either. Off we go left on here. A lot of large pressure sores. If you do know someone who's a bit more elderly, just tell them to move about a bit more often. Don't have them sat down all day not moving, because honestly some of the pressure wounds I saw particularly horrific, especially some that you can literally stick your fist in them. They are horrid, but so easily preventable. So if you know an elderly relative, just tell them to just change the position, stand up a little bit, even if it's just for a couple of seconds every few hours, and that can really help to prevent them, because how that works is, so if you sat on something for a long time, the blood vessels are squashed, aren't they? So blood vessels carry oxygen, your skin and your tissue needs oxygen to live. So if you deprive that source of oxygen, because you sat on it, so the blood vessels are closed, and that skin there is not getting any oxygen, it then dies. So it starts by turning a bit red, a bit pink, a bit red, then before you know it can just open up into these massive things that you can literally see people say come bone in, and I've seen lots of them. I think I've probably grossed you out enough, aren't you? And the point was, seeing little minor fungal infections like this, it really doesn't bother me, because I've seen it all before. And worse, I really have. But we're not far off the end of this now. You know, I'm more than happy already with everything that we've done. And so yeah, as you can see, this little U-shaped area there, that's the cavity. The mastoid cavity where it was drilled away and removed. So I'm fairly happy that we've managed to remove as much as we possibly can from there. But there's no way you can eradicate all of this fungal infection from this ear just by hoovering it all out. Bits of it are still going to be there, and then it's going to breed, and then it's going to grow again. But giving it the best chance it can. We can see a lot of pink in here now, which we certainly couldn't before. And like I said to you before, I'm not entertaining going on that fake eardrum, that reconstructed eardrum. I don't think it's worth the risk. It's only a thin layer, I think, that's there anyway, but that's way too risky to go down there. But I'm more than happy we've got more than enough pink exposed there. You can almost see straight through to the bone there, can't you? It's very, very thin, the skin that's left there. But I'm more than happy with everything we've done so far. So I think we've got some images. I've got a few, so hang around. Got some really interesting ones. So I think this is the one that you saw at the beginning. So you can see the little spores, can't you? They've got a hyphae, aren't they, like cotton wool? And some of them do have little heads on them, don't they? In the same way that a mushroom would. That's why I don't like mushrooms. They're absolutely horrible. They shouldn't be eaten. It's not food. And here they are out of the ear. Like I said, not much, and that's a close-up of that bit. The bigger one, with all those spores on them, and have a look at all this outside. There you go, look at that. No, I'm only joking. This is not what we pulled out of here.